I'm going to talk to you primarily as a patient today. We're all providers of healthcare, but at some point, I think it's pretty much inevitable that we'll all become patients. Many of you will be patients already. And I think it's when you become a patient that you really begin to understand what being a patient actually means. I worked as a psychiatrist for 33 years in the north of England. I arrived in Manchester in 1980 and worked about a mile from here. I was a consultant psychiatrist for 23 years, and I was also an academic. I was a professor of primary care psychiatry, and I spent a lot of my life researching anxiety and depression. But I've been a patient of mental health care since I was a medical student. I developed depression and anxiety when I was in my early 20s. And I think it's really important to say that anxiety and depression, not only is it common, but depression is much, much more than sadness. I know that there are quite a lot of people who find that sometimes hard to believe, but it's a really much more, it's a different feeling. It's a feeling that there's no future, that life is very grey, it's very bleak. It's a very debilitating illness with physical as well as mental health symptoms. And it isn't just a list of symptoms. It isn't a single phenomenon. I don't believe there's one kind of depression. There isn't a single cause for it. Physical health problems can cause depressed mood as well as mental health. And it's often triggered by loss. It's a biopsychosocial phenomenon. And having depression both detracted from and enriched my ability to work as a professional in the NHS. I think, like many doctors, too much of my self-worth was tied up in being a good doctor. And I burned out on a number of occasions and became severely depressed and had to have several months off work. And I would say that all of this talk about resilience is quite difficult for me because I'm not a very resilient person. I have real concerns about the emphasis on resilience and the focus on the professional rather than on the system. But I think what experiencing depression really did for me was that I was able to empathise with my patients. I did know what it was like to sit on the other side of the room. I did know what it was like to sit in the outpatient clinic. I hid my problems at first. I had tremendous guilt and self-doubt. But when you have to have time off work and you have to go through appraisals and revalidation, you can't do that. You have to be honest. Sometimes I had to share my experience of my mental health problems with people that I really didn't want to share them with. But I was able to come back to work each time, and I made reasonable recovery. But I'd say that the NHS did not prove to be a great employer. You would imagine, working for a mental health trust, that they might have had some sympathy and understanding for people with mental health problems. I have to say that mental health trusts, in my experience, are not model employers for people with mental health problems. There was a famous occasion when I came into the hospital to collect some things, and I was spotted by the personnel manager and received a letter from him 2 days later saying, "I looked so well, when was I going to return to work?" I was actually employed by the university, and I got them to send him a letter saying I might look well, but I couldn't yet function as a doctor. What I know from my own research, and I spent quite a lot of time talking to patients about the experience of depression over the years, was that the problem with depression is, as we've heard from other speakers this evening, that you have a sense of wasting the doctor's time when you get depressed, and you don't look after yourself because you don't really see the point in it. So that the experience of being depressed actually has a major impact on the process of accessing care. And I've spent most of my life researching primary care, and people who think they're wasting the doctor's time and don't deserve to feel better don't go back. What helped me were a number of things. A lot of talking therapy, medication, which I've actually been on now for 25 years, and I'm still able to function. I don't think I would have written all the papers I had published had I not been on it. But perhaps most importantly, continuity of care. I've managed to see the same doctors, and I've developed trust in those doctors. And I think that's really important, and I think that's something we're really in danger of losing in medicine. Tablets are never the answer on their own, but I do think they work. But I'm going to say a bit more about mind-body interactions, because I retired at 58, partly because of my mental health. My husband said, it's really time you stop pushing yourself quite so hard. But the year after I retired, I was diagnosed with polycystic kidney disease. And this was somewhat of a shock. And I actually went through a bit of a grief reaction because I'd so looked forward to retirement. And then I was grieving for this wonderful future beyond work that I didn't have. I had chronic and persistent symptoms, which no one could find the cause of, and I began to think were medically unexplained, which I thought was interesting, seeing I'd actually spent quite a lot of my time researching and treating people with medically unexplained symptoms. No one could ever find anything in my MSUs. And then things got very much worse about 2 years ago. I had really severe hematuria. I had to go and have another cystoscopy. And within 5 days of that, I found myself in the A&E department. And I was diagnosed with sepsis. And this was on the hospital site that I once worked. And it was interesting, bearing in mind what we've just been hearing, because the psychological medicine unit that I'd worked in that place in Yorkshire had been demolished. And there was no longer any mental health input into that ward, because the psychiatric unit had moved up the road to its own little island. It was an experience that I could write a whole book about, but I'll just say a couple of things about. No one introduced themselves to me at any point during that, apart from the one nurse I met who said, "Hello, my name is," and she was a student, and she was wearing the "Hello, my name is" badge. There was no continuity. I never found out who my consultant was. The attitudes of staff towards emotional distress were fairly appalling. I was really distressed when I was in pain, and I had this sense that there was no safety net because there was no one apart from one or two really sympathetic nurses who'd been inpatients themselves, who seemed to understand what it was like being, and I was at times delirious. I was convinced that there was a tube station just below the window and I could hear trains coming and going. And anyway, I made a full recovery. And after recovery and quite a large amount of gentamicin, all my UTI symptoms disappeared, which I thought was interesting, given that I thought they were medically unexplained. And my psychiatrist, who has spent his time scanning people's brains who have chronic infection, then proceeded to tell me about the latest inflammatory theory of depression. And it certainly seems I had had some kind of chronic infection. I don't know, but my mood had been unstable for 2 years. And my mood problem has now been more effectively treated with gentamicin than anything else. Last year, another mind-body interaction happened. I have kidney disease, I have hypertension. I was put on amlodipine. And I just wonder how many of you know what effect that can have on your brain, because I became suicidal on amlodipine. I had an acute relapse of depression, and I had to come off it. And my psychiatrist had seen several people with that interaction, but I got the impression that some people didn't know about that. I think this Cartesian divide of healthcare provision needs to be challenged more urgently than ever. We've got to much better integrate how physical and mental health care are linked up. It certainly came home to me when I was in hospital, exactly what that felt like. I felt a long way away from mental health care. Fortunately, perhaps because of who I am, I had a psychiatrist that I could phone up on his mobile. And he was actually at a pop festival at the time, which was interesting. And we had a conversation, but I couldn't have that kind of conversation with anyone else. I've learned quite a few things about how to cope with mental health problems over the years, and given that the next talk's going to be about our own care, I'll just share one or two of the things I've learned. What I know is that each time I've had problems with my mood, the part played by biology, psychology, and simply what's been going on in my life have been important to a differing degree. My friendships have been really important, listening and talking. The people that I remember very clearly are those that I was on a medical firm with and a surgical firm with as a junior doctor, and the people I trained with. I think it's really, really important that you find a passion in life outside of medicine and you pursue it. Do not make medicine your only passion. Find places that are good for your sense of well-being. I now live in Scotland half the time. Take care of yourself and be kind to yourself. Doctors are really, really bad at being kind to themselves. Yes, we have to lead a healthy lifestyle, and we've heard quite a bit about that and the need to lose weight and look after ourselves. But the problem is that many of us are perfectionists, and it's very, very easy to punish yourself for not being good enough at losing weight. And don't be afraid of asking others, are you okay? And just an advert for my academic book on the left, which was the second edition of Primary Care Mental Health, published by Cambridge, and my personal book on the right, The Other Side of Silence. Thank you very much.